Okay, so we are here for episode 1, season 2. Warren Bodine, thank you for joining us.
Thank you for having me.
It's a pleasure. It is a pleasure. So we have a whole pile of stuff to get to here. I just want to let the guests know, or if we have some new people here, that it's a live broadcast. You can catch it recorded later, but if you have questions, throw it into whatever chat box, which you might be on Facebook, YouTube, LinkedIn, throw it in there. If I see it pop up, we'll chat about it. So I have a whole pile of things to get to with you, like 3, 4, maybe 5 things that I really want to get into.
Yeah.
And I'm going to start with like surface level stuff. So
Sure.
you and I have talked privately about this stuff, that it's not really as big a deal as probably most of the laymen think. But we have a lot of folks here that are not in the healthcare industry that watch this as well.
Of course.
So one of the things I want to throw out there is, you know, you're a seasoned veteran, you travel a lot, like we were just talking before here, you've been all over the country, even in just the last few weeks.
Yep.
You've been traveling quite a bit. So I try to picture a scary curmudgeon, let's call them Will Welichek or something like that, come over to you, right? And you're a rookie, you just got out of residency, you're new, and you have this guy that's extremely demanding. So, you know, I think the medical tent is one of the few frontiers that, because people who are into sports, they learn everything about their favorite athletes and their favorite teams. They know where they live sometimes, and they're following them on all social media, who they're dating and everything. But we don't know what happens in that medical tent. So in that tent, and I have several questions here. What is it actually like? What's the atmosphere? What is the access situation? Can coaches get in there, and how does that work?
Yeah, great question. So it's not as elaborate as maybe it looks like it's on TV. It's essentially a tent that sometimes we have a light in there, which is nice, and sometimes we don't, depending on the time of day. Sometimes we're using cell phone lighting. It's essentially a tent with a examination table that's in there that folds up, that we put in there before the game, and we'll have some access to some medical supplies immediately in the moment. But usually the first point of contact is usually the athletic trainer for that particular team. And most cases, we're probably talking about football here, where you're seeing that medical tent.
Right.
So usually a player is escorted off the field. Usually they're putting some weight on their extremity. Maybe they're being carted off. But let's just say they're getting to the sideline. So they get to the sideline, we get them into the tent to do an evaluation. And the purpose of that is twofold. It's to maintain some privacy for the athlete, because we know in a venue such as a professional sports arena, stadium, there are eyes, cameras everywhere.
Yeah.
Right. You know, and
they're trying to find any information they can.
Any nugget of information. Right. Exactly. They want to know information. So they're first on the story, and then maybe not as genuinely, maybe our opponent is looking to see what's happening with that particular athlete as well, and saying, all right, is this going to influence the way we play the next couple of downs or the next series, because so-and-so may not be out there.
Sure.
Right? So there's a lot of different eyes that are on this. So to mitigate that, the tent gives you that ability to have some privacy, to actually do a full exam on the athlete and to make some decisions as a medical team. So usually the access is usually the athletic trainer, usually with 1 or 2 of the physicians, and usually for football, you're going to have a orthopedic surgeon and a primary care sports medicine doctor right on site on the sideline. And depending on, you know, different venues, you might have an emergency medicine physician there as well. It depends on really what the needs are for that particular venue or that sport. But typically you'll have the decision makers essentially in that tent.
Now, can the coach get in that tent?
That's a great question. We try to avoid that. We try to push back on that, and we try to maintain a clear line of communication with coaching staff. And, you know, more often than not, the game's still going on, right? So I think that's the thing, is unless it's a catastrophic injury that time stopped and ambulance is coming on, you're not even talking about the tent at that point. That's a person that's probably getting shipped right to a hospital. But, you know, for an injury, you'll have a little bit of an injury timeout, get the player off the field. You know, the public is probably just seeing that the TV goes to a commercial, comes back, and then they're back to playing already. Right? So it happens that quickly.
And you say it so calmly, but I'm picturing too, like, this isn't a walking, like where we are right now. So where are we? I don't even know about this area.
Yeah.
This is part of
Mass General Brigham. Yep. So before this, in Lawrence. So prior to this, it had just a different name on the building. It was Pentucket Medical Associates.
Okay.
So it's one of the legacy sites for Mass General Brigham.
That makes a lot more sense. Okay, now I understand where we are. But I'm picturing it's not this environment. This is a adrenaline filled, like an adrenaline junkie environment. Like, I mean, I remember seeing Matt Stafford break his collarbone, come back one down later, so we've seen people who are clearly have no business being back out there, somehow either being cleared. So I guess part of my question too is, how much decision making do you have versus the patient versus the coach versus where's the liability here? Because I'm sure, even though that's an extreme case I just brought up, there must be times where there's a mistake made. You send somebody back and they immediately get injured and you're like, oh shit, why, and you second guess or whatever.
Yeah.
So where ultimately is that decision made? Or does it depend on the situation?
Yeah, I think it depends on the situation. I mean, I think most medical models, when we talk about sports medicine, it's going to come down to the head team physician that's in the tent in that moment.
Okay.
And, for example, if this was more of a concussion case, then that decision would lie probably more with me as the primary care physician.
Okay.
If it was more of a musculoskeletal, significant ligamentous injury or questionable fracture, then it would likely lie with the head orthopedic team physician that's there at the game. So, but yeah, I mean, minutes count, right? Minutes, seconds count. So the minute that athlete goes down, we're already, again, we always have eyes on the field, and just the communication that happens behind the scenes. We all, especially for football, it's a loud environment. We all have earpieces in attached to radios that, because again, if you're along a long sideline, something could be happening there in the defensive end.
Right.
And meanwhile, over there at special teams, something's happening. You don't even know it's happening because it's literally 50, 60 yards away with a sea of humanity, usually big humans that are blocking your view that you can't see, and you're distracted by.
Oh my God, yeah. I remember when I was a teenager, I hung out with some Division III offensive linemen, and they weren't even crazy tall, 6'2", but their width, the breadth of their frame was just massive. So, and you work in other sports too, so this must be different than, I guess, sport to sport. So you were just in South Dakota with the
for ice
hockey team, right?
Yeah, for Merrimack ice hockey. Yep.
So when someone gets, and you have a totally different breed there. I imagine, I would love, God, I don't know if you can actually say which sport has the toughest athletes, but it's got to be hockey. There can't really be a question.
I mean, I'm not going to refute that, but I mean, every sport has its identity, right? I mean, I think you're going to see there's different cultures within different sports and different nuances. And ultimately, it comes down to the individual athlete that you're seeing in the moment. So that continuity usually will come from, whether or not myself as the physician have interacted with that student athlete or professional athlete before, to kind of get to know, all right, what's their background, what's their history with injuries, how do they handle pain, because everyone reacts differently, right? That's not a negative comment about that. That's just the way people handle pain, right?
So conversely, are there situations where you might have someone that you want to clear, and then the student themselves, the athlete themselves choose, I don't want to go back out there, and they say something to you confidentially. Do you then have that responsibility to speak on their behalf and say, we're not clearing them?
Yeah, no, definitely. Yeah. I mean, I think all those decisions, to get back to your original question, it's always going to be the healthcare team. And I'll say, because I'm a physician that's talking to you right now, it's physician centered, but it's, physician led and then patient centered is what I would say. So, we make a medical determination. Is this athlete, appropriate to return to competition? And even that decision doesn't necessarily happen right there in the tent. So, if we're like, all right, it looks like you maybe have injured your ankle, we can maybe provide you more support, tape it up, but we're going to do some provocative testing on you and some testing on the sideline. Then
like some PT testing, like walk here and there.
Exactly. So you're going to do things that might be more specific to their role or their position or whatever it is that they're doing for that sport to pretty much mimic what would then happen when they're out there.
And it's crazy too, because sports, especially in this country, seems to be insanely diverse. Like when I was doing my research for this, I looked up, what is it, in the Winter Olympics has this sport called, I think a biathlon, something like that, where you're skiing
and you're shooting.
And then you're shooting. Okay. So, I guess, and we all know, there's always an escalation. You run your 10K, you run your marathon, you run your ultras. Now you're into your ultra triathlons and all this insanity that just seems literally impossible.
Yeah.
And it's great and or whatever. But so every athlete you train or you're working with, I imagine you have to look at them in unique ways. So one thing I came across too was Tommy John surgery is up 3.5 times for this current generation than in the past, and that over 50% of current patients are like students right now at that level.
Yeah.
Which seems crazy to me, but it's because of, I guess, how far back that bends or whatnot. So when you're, depending on which sport you're dealing with, your approach must also be different because you know what they need to know. Like, so a runner isn't going to need their ACL as much as a football player that's going to have to be moving side to side, right?
Correct.
So you bring that into every one of those.
You have to, yeah.
Right?
You have to change your mindset for every sport that you're going into, right?
It's crazy.
It's a little bit, yeah. So, and you also have to have that exposure. So you mentioned an ultra marathon. So Massachusetts, believe it or not, did have an ultra marathon that was hosted by a group called the Trail Animals Running Club called TARC.
Okay.
And I was their first ever medical director.
Oh, and it was on a trail?
Yeah, it was on a trail. So it was a 100-mile race that was done within the woods, and it was 4 25-mile loops that were done over again, completed within 30 hours.
Yes.
And I would say going to that event, again, you're in the woods, right? And mainly a lot of darkness and nighttime.
Sure.
It's a different vibe. It certainly was.
Yeah.
But it was really good to just be part of that energy and just part of that crowd. And, I think realizing that I was asked to, and I got connections behind the scenes that said, hey, we're looking for someone that can help us just manage the medical side of this, right? And I go, well, I'm not an ultra marathoner myself, so I leaned into a lot of my colleagues that handles races like this out west. But my most humbling moment was having to write the dead runner protocol. So what do we do if we find a runner dead in the woods?
Yeah,
right.
I had a friend like that. He did his third loop.
Yeah.
I think it was mile 78 of the exact run you're talking about. And I think it was a hamstring or something.
Yeah.
Like that's got to be so terrible. And then you're 3 miles out. And
And like, how do we extricate the athlete?
Right.
And how, we actually ended up having to airlift someone out because of a stress fracture of their hip.
And even just getting an airlift in there has to be very challenging.
Very challenging.
I remember, so I did the Ragnar races a few times. I'm sure you're probably familiar with those. And those ones you have, everyone at some point has to run in the pitch black. You have the headlamp on, and I remember just simple things. You're running on a sidewalk and it's black on black. I remember folding my ankle terribly once in the beginning of like I think that was a 6.5 mile leg that I was running at the time. And it's just, it's wild too, because the adrenaline's running through you. So then you end up trying to push further, and, you don't want to quit. You don't want to ask for help.
Right.
And
because there's so much training and so much commitment and things you may miss, as depending on where you are in your life. If you're a parent, training for these races, you're not just waking up one morning and say, I'm going to go run an ultra marathon. That's going to take months, years of training and, runs and things that'll take you away from those activities. Yeah, so it certainly is a lot of commitment. So you have to also keep that in the back of your mind when you're making those determinations for some of these athletes. And again, I'm coming up, from in the Northeast, we have the Boston Marathon coming up in a couple of weeks. So I've been a finish line physician for them since 2010. And, you have to realize that that's also a different mindset, right? You have runners, again, we usually don't see more of the elite pro runners. There's a specific tent for them. And they go off into their elite tent. And more often than not, there's not a whole lot that's done over there. It's more of just, I think, the badge of honor to say, I take care of the elite. And then when those team members, our medical team members are done, they'll come to us more humble folks that are dealing with everyone else, the rest of humanity that's running. But everyone has a reason that they're running. It might be they're running for a charity. They're running for a person that was stricken with a disease. They may be running in memory of someone they lost. Obviously 2014 was a more emotional race after what happened in 2013. So, you're spending, maybe
I didn't know it was that long ago.
Wow. So some of the protocols you may apply in normal everyday life, you might have to stretch those boundaries when you're dealing with athletes in those venues, but also maintaining a level of safety for them. But maybe not saying absolutely no, you can't get back out there right now.
Let me ask you about, let's start bringing up some controversial stuff. This is where it gets fun. So this is something that I know very little about, but I've just recently started to tap into. I was telling you earlier about how I was talking to that, I just recently found that women's sports group out of Brighton that's just started up a few months ago. I'm starting to learn recently that there's a difference between women's sportsmen, medicine, and men's. And somebody that follows us had reached out and said that she's had a couple instances where she came in for an injury and was asked questions about emotional stability, like was she menstruating, was she going through a breakup or something like that. Which, so I guess one of my questions, which is funny because when it comes to toughness too, and I'm out of my depth here with this stuff.
Yeah.
But just I know. Like I have a good friend who's a tattoo artist who will always say, like, women always have it in the hardest places and they never really get upset. Men whining and cry about it more than, like, they have lower pain thresholds than women do. So I guess my question is, is there a distinct difference between the two, and what is it and why does it occur?
Yeah, I mean, I think it's there's still more and more emerging literature and research that still needs to be done. And I think kudos to a lot of healthcare organizations and even some of these independent groups that are, making sure that those resources are available to female and women, athletes across the spectrum of their lifetime to tackle those issues, right? Most of the literature in orthopedics and sports medicine was done on men. Right. So, and
because traditionally men would be always in the forefront of athletics, still are, I think, from a marketing perspective and things like that.
Right.
But you have women climbing Mount Everest now. And
of course.
So, I mean, I imagine that as much as, and again, I'm coming in blank, so please correct me on this.
Yeah.
My first thought was obviously they should be treated equal, but then I'm starting to think, but physiologically, I imagine there are actual significant differences, and maybe it is a lack of focus from the medical community specifically on women and how athletics interacts with their chemistry. Is that true?
Yeah.
Okay.
I mean, I think that's probably a fair statement. I mean, again, we deal with the reproductive system of women is different than men, right? We know that, right? And if you think of your body as a machine, you need energy to do all of that, right? So when you have a athlete that's competing that is of menstruating age, you have to take this into consideration of what does that look like for their menstrual cycle? What does that look like for their bone health? What does that look like for the integrity of their ACL at certain points, or their susceptibility to injury at different points of their menstrual cycle?
So even asking these questions is not like, so my friend who took this as an insult, like, you're not taking me seriously, you think I'm being emotional. It may have actually been a diagnostic tactic that maybe, so,
maybe not are you going through a breakup question, but right.
Okay.
Yeah. Maybe that
would be irrelevant.
I mean, again,
well, like
maybe it was appropriate, but it sounds like maybe probably wasn't.
Last week I was at the Mass Medical Society, had their annual event, and the keynote speaker was great. He was one of the people who was appointed by the White House during the pandemic for a lot of the communication. He talked about how poorly they did at communication, which was something that's refreshing that you don't see people talk about much, where obviously there were a lot of great things done, but there was a very short window and they spoke a bit more confidently about certain items than they should have. And he took some ownership of that, which is great. But I think, one of the things that I see coming up a lot, and this is even beyond healthcare, but is the communication gap sometimes between patient and doctor. So if we're just focusing on that. So if that is something that's important, to explain why they're asking that, to qualify it, because for you guys, this is second nature. I'm going to need this to understand whether it's a hydration issue or whatever it is that's going to be associated with this, that understand that a woman might feel a certain type of way about you asking a personal question like that to them. Of course,
yeah. I mean, I think it's important to level set why you're having those, why you're asking those questions and giving kind of some context for that, right?
Yeah.
You're seeing an athlete in an orthopedic office, usually orthopedic, the vital signs in an orthopedic office is usually what's your pain level, height and weight, maybe.
Right.
And then that's about it. Right. So now you're delving into, to get an accurate history on an athlete, you're asking some of those more sensitive questions, which may be perceived as sensitive and maybe insulting to the patient in the moment, does have some clinical context and value. And maybe it's just coming from the wrong, speaker.
Right.
Coming from, and it's just unexpectedly asking that. And I own that. And I'll say that, typically you're probably not going to be accustomed to be answering these types of questions in this venue, but it's important for us to know X, Y, and Z. And, especially for my younger adolescent, teenage patients, female patients, they'll have parents present. So I just level set, like, listen, now I'm going to ask you a series of questions regarding your menstrual cycle and things of that nature. And that it's really important for us to get some clinical information on that, just to help guide our kind of process moving forward and to seeing whether or not what we're dealing with currently is impacting your particular orthopedic issue that we're
Great.
addressing.
Okay, that's really interesting. Okay, so now let's get into, so you and I met when you were over at Greater Lawrence Family Health Center, which love the hell out of that institution. And you did not only a lot of great work there, but you also worked with the residents quite a bit over there too, right?
Yeah, I was one of the residency
How'd
program
you like that?
directors. It was good. I mean, again, residents, teaching residents, it's not an easy task by any means. And, like anyone that's in a teaching profession, you always have to be nimble and, maybe even recreate yourself every couple of years in your teaching style and individualize that to the people that you're, teaching to.
Sure.
So I think that, and I think what will be interesting now moving forward in medical education and residency education in particular is how do we, manage the crossroads of traditional medical education, inserting AI tools, and how is that going to interface with
which I think everyone's struggling with right now. But like from a specialty to specialty, it's different. I've noticed those conversations are all happening, but they're all happening in very different ways between specialties.
Of course,
for how you can interact, how you can integrate it.
Yeah.
But most of your work have been for health systems, correct?
Mhm.
You've never worked in an independent environment outside of what you do as like a consultant and your work with like Boston Marathon and the Red Sox and stuff like that.
I've always worked in a larger medical kind of institution. Started with Cambridge Health Alliance, started the residency program there for a couple of years. Was with Greater Lawrence Family Health Center and teaching at the Lawrence Family Medicine Residency from 2013 through 2022.
Yeah,
and then this newer endeavor with Mass General Brigham.
Awesome resume, I love it. Which leads me to this question. So what I'm starting to see a lot, and I think is going to break out a lot this year, is a lot of work where folks are getting their imaging outside of these institutions, whether they're finding if they don't have to go in to like my fiance has brain cancer. So she twice a year needs to get an MRI, and she's been going to Rhode Island Hospital for it. I'm like, why don't you go to another imaging center? Instead of dropping like a couple grand, you can drop $300, $400, $500.
Yeah.
And she had no idea about that. And she likes her doctors, and like a lot of people do that. But I'm like, it's really going to just be some, I don't know. But I guess my question to you is there outside of so I'm looking at that strictly from a cash perspective.
Of course.
Is there something that should be, is there a significant difference between getting, your x-rays or other imaging outside of these institutions? Is there something lost? Because I imagine most of the facility costs is really just kind of going through the whole facility process. There's so many different individuals you have to check in with to get from A to B and book your visits. So
right. Yeah. No, I mean, I think it's a great question, right? I mean, I work within a large, system within Mass General Brigham, and there's a lot of touch points that patients in this area can access that. But sometimes that's not always in the best interest of the patient, right? Hours wise, maybe their particular insurance isn't taken by our institution, what have you. So ultimately, from my vantage point as the physician that's taking care of just patients in general, not even specific to athletes, as long as we get access to that information, that's really what's most important. And the difficulty, especially within orthopedics, is that, there are certain protocols that we'll have for particular imaging, just even saying for x-ray, if you're looking for an AC separation, are you doing that with a weighted view? Are you doing an ankle sprain? Are they weighted views? And sometimes, patients hobbling into an urgent care center, they're not going to be like, all right, now put weight on this because we know the orthopedic that's going to see you. They're just going to do their job and head down and just get a picture just to rule out a fracture.
Yeah, like someone can have a labrum tear and you're going to be like, this is what you need. And then they go somewhere else and you're like, oh, I wish they had run contrast in that. And I'm not getting the information that I wanted to, but I'll work with what I have. So it can be frustrating.
It can be.
But ultimately, as long as you have access to that information, you can continue the treatment properly for the patient.
Exactly. And I'd say myself and my staff spend probably an inordinate amount of time sometimes to get that information and just to get the images shared with our institution.
Yeah, I think that's one of the most difficult things that, we were expecting with EHR to have that health information network to really connect. And people have been talking about that now for a very long time. And you're just, you're not really seeing it too well unless you just have some large system like what we had with Steward, what we now have with Beth Israel. But it's, I think it's a frustrating process for a lot of people to try to get that access. But
I mean, I'll have patients sometimes even come in, even my student athletes at the college, they'll come in like, oh, I went to the urgent care across the street and I have this CD. I'm like, my computer doesn't even have a CD-ROM drive. I can't even
Yeah.
look at this.
Yeah, I got one of those from Sturdy Hospital the other day, and I'm like, I didn't know people were still using these things. Like
Yeah.
that's wild to me. But yeah, some people have. Yeah, I mean, there's I mean, even Encompass Health, who I do some work with, they just had their first EHR in like 2018. And they created their own, which is insanely late for a facility. And granted, rehabs usually lack in tech, kind of like sniff stew and whatnot. But it just, at times you just feel like things are just way too archaic. I mean, I felt that way about telehealth forever, and it took a damn pandemic for us to get it into this state, which I think is, I mean, I'm glad it's here.
Yep.
But it's been something I've been fighting for a very long time.
Right.
All right, so let's get into some other stuff here. So ambulatory surgical centers, so talk to me a little bit about their place right now in medicine. So I think it's a similar situation. My understanding is that I'm not sure if it's impossible, but it's very highly regulated for independent clinicians not to open up their own unless they have a relationship with a large health system or with a payer in the state. So is that something that you think stymies innovation, or do you think that's a necessary regulatory item to ensure a compliance so that something doesn't go too far out?
Right. Yeah. And I can't say that that's my level of expertise, but from my vantage point, I would say that being tied to a hospital system from like a joint commission perspective, making sure they have some accreditation, certainly level sets to make sure that those ambulatory surgical centers are on par with, the ones that may be affiliated with the larger hospital systems. But then there's obviously the flexibility, if it is a surgical center owned by a group of physicians, of maybe more flexibility with staff and scheduling and things of that nature that isn't tied to the hospital. So I think there are those advantages. And even my son, who had his tubes in his ears a couple of years ago, was at a outpatient surgical center up in Salem, New Hampshire, and not tied to a local hospital system. And beautiful facility. That's where I'll probably get my colonoscopy this year, and that's where he got his tubes done in his ears. So it definitely, and then you're in that waiting room, and you see the names of a lot of your local groups that are up there. So I know there's orthopedic surgery happening up there. There's ENT surgery. There's obviously the GI side of things from the scopes. So I think that the convenience there from the physician vantage point of getting folks in scheduling might be a little bit more palatable than dealing with a larger hospital system.
I think without question. And then also limited exposure to infectious disease, things like that. I mean, I think even just from the telehealth perspective, not that plays a huge role with you guys, although I know you guys can do a lot of like follow-up type of stuff to make sure things are going well over that. But I think all of that work goes to potentially having other issues popping up. And so I'm always loving seeing like the incentives for these hospitals to have a lower patient population and kicking people out as quickly as they can. That sounded a little bit harsh, but you get the idea.
Of course.
Okay, let me just see if we have any questions yet. I don't think I see any. Oh, hold on. Let's see. Comments would be down. Where were they? I got to get myself back into this stuff. Okay, I don't see any comments yet. So let's take a little piece about what it's like for you from your perspective with, I mean, I don't know how many jobs you have. I was talking, I made a little joke about your, the letters after your name. I'm going to put them up there.
Of course,
Do you even know what all those stand for?
Most of the time, yeah. So
I'm like, oh.
Yeah, I just always wanted a backside to my business card.
Oh, is that what it was?
What
Okay,
it was.
Like a to be continued, and then you can flip it around.
On over. Okay. Yeah, so they're just indications of the different credentials I have within my primary care background and training and sports medicine training.
Yeah, so that's one thing I've noticed too. I mean, and you spoke a little bit about this earlier, is that there's all these subsets. So even in the medical tent, like you were saying, you could, and it's not just like surgeon to medical, but it's even subsects in medical for what their focus is on. So what are the different focuses in, so you said there's ortho, there's more of like a primary care, which you would fall under.
And then obviously there's crossover as well, right? So not every orthopedic issue is surgical, right? And that's not just saying, just to put orthopedic surgeons in a box of saying they're only there to talk about surgery. They're not, right? They're also experts in musculoskeletal diagnostics and return to play protocols and making sure athletes are safe to go back to their particular activity or sport.
Yep.
But there's also that crossover with primary care sports medicine as
Mhm.
well. So they both have a role. And then in that setting, you know, that kind of hierarchy is kind of established before those games and
Right.
those particular events to say, all right, this is an ortho issue, it's going to be so-and-so's call. If this is more of a primary care, you know, injury, concussion type of situation, let's say there's an eye injury or things like that, maybe a groin injury, that's going to be falling more under my jurisdiction.
Yeah.
But it certainly, you know, there could be a time where there's multiple things going on where maybe someone gets pulled into the tent and I'm just right there. Meanwhile, my orthopedic colleague may be down the sideline dealing with something else.
Yeah.
You know, it's not like, all right, I have to make this, you know, we would do it in consultation with one another.
Right.
And I know it always seems, again, time is always of the essence in athletics and sports medicine. But in a situation like that, sometimes you have to be humble and say, all right, yes, I have someone who's got many more years of experience as a surgeon dealing. This is literally their expertise. I'm not going to ignore their, you know, guidance.
Exactly. Even if you're 90% sure of what the next course is, that's not good enough. You want to make sure it's
right. And I think it's all, and again, you have to, it's always being done through the lens of what's the best for the patient. Right. And I think that's always the difficult thing. And sometimes, you know, you're an athlete, you want to be the best at everything that you're doing, and your athletes are competing at the highest level. And I think sometimes there's that mentality, even as the healthcare team, to have that. But, you know, realizing we all have our different roles in administering healthcare to the athletes, whether they're professional or student athletes at any one time.
Okay. So what's the most challenging part of that then? Like, have you ever been like threatened by a coach or anything like that?
No. I mean, I think there's situations where, you know, you want to build that camaraderie, you know, and again, you know, and you had mentioned I just traveled all over the place. So I was just with Merrimack men's and women's basketball for their conference tournament earlier this month, and then just wrapped up the NCAA men's ice hockey tournament out in Sioux Falls, South Dakota. So you're traveling with these teams. You're with the coaches. You're with their families.
So you even have a camaraderie with them. Okay.
Yeah. So you start to build that rapport, and you know they'll start asking you questions. It's not like you're like isolated on the team bus and
That's
like
how
don't talk to me.
It was.
No. You're with them.
It's not like you're the kicker, where it's just like, who cares? Got it.
I mean, you're giving high fives and fist bumps to the athletes as they're getting off the bus, coming back on the bus. You know, you're part of the team. You're part of that family. So I think that's important. So when you go in with that, and will there be times there's maybe some you know, times where you may not agree? Of course, there might be some times of that, right? And there might be times that, you know, someone's emotional in terms of like a coach or a staff member that is really wanting to get so and so back out there. Be like, this person can't put weight on their leg. Like they're not going to be effective. I know it's the championship game, but they're out, right? So
it's gotta be really tough. And I mean, I'm sure sometimes the player is also just doing the same thing. Like, I know I can get out there. Like, you don't know what you're talking about. I've gone through. I'm tougher than you think I am. You don't know, whatever it is.
Right. And that's where you have that level of objectivity of saying, all right, now we're going to do some provocative testing on you that would mimic what you're doing on the you know, court or field or whatever avenue you're taking.
What about mental health? So do you ever have mental health in the back, or whether it's in the tent or inside the stadium or something like that to assist? I mean, I would imagine it's mental health typically comes in more for chronic issues than it does for acute issues. But, you know, where do you see the place for mental health in sports med? Because it definitely has a role.
Oh, of course. I mean, I think, you know, and then you look at the different avenues and the different stressors for an athlete at any point, whether it's collegiate athletics, which again, being a Division I collegiate athlete and going to school, those are like 2 full-time jobs, you know, and I would even have a hard time managing those schedules, you know, and so, you know, you translate that into the professional realm, and you have more resources and more support, but the building blocks are there throughout the course of their lifetime in athletics. And you know, I think they play a critical role, and it shouldn't always just be that they're swooping in when there's a crisis, which I think sometimes is when we think of mental health, right? You know,
I think even physical health is like that too. I mean, we're largely, I think, in medicine retroactive.
Yeah, of course. Know? Yeah, reactive instead of proactive. That's the way we always say
reactive.
It.
Sorry.
No, being reactive. And I think it all comes down to what your resources are like, right? And a lot of organizations, especially collegiate, are operating under those models where it's more of a reactive to the moment of what's happening, which fits what needs to be done, but you take a step back and you say, all right, well, what maybe led to that that injury that we're seeing right now could have been prevented by, you know, more of a thorough biomechanical assessment of those student athletes at the beginning of the season. But if you have an organization that has a strength and conditioning, you know, program that's embedded within there and only a handful of athletic trainers, and you're trying to get, you know, 1,000 student athletes through, and they're different, it's just not going to happen. It's a nice to have, but it's not a thing that's going to happen all the time. And that's where I can see, that's where I see some of the differences, obviously, from a you know, mid-major Division I school versus the professionals, right? In the professional realm, you know, they're getting all sorts of biomechanical assessments the minute they hit spring training, and you know, looking at the different, you know, aspects of what we need those athletes to do. And, you know, as you kind of mentioned, Tommy John surgery and looking at external rotation, you know, we look at that on all of our pictures, and we look
even
at where
from
the deficits are.
Even from a proactive standpoint, when you get to the elites, when you get to the,
of course.
So do they, I mean, and then I guess you wouldn't really, because I would love to see that with like social determinants of health. But anyone who's being paid millions of dollars, I imagine that's not really a big issue for those populations as much as it would be for, like, obviously the folks in Greater Lawrence. Or, but I imagine even in the collegiate level, there's probably some value there too, to find out what's going on at home, what's their environment like, and diet and money, electricity, all everything. So so it's, I guess, almost unfortunate or ironic that you're going to have all the ability to do that for the folks who probably need it the least. And conversely, it's always like the most vulnerable people in populations that never have it, and they need it the most. I mean, I remember when I was running my own pediatric practice a few years ago, we found a couple children who were off the grid, like 8, 9 years old, that weren't even in the school system. And it's like, holy shit, like we need to have that, but there's so many more patients there, and there's so not the money to fund that, that it's always very frustrating.
No, it's often, even in my primary care practice here in this building, I'll sometimes ask them, like, all right, you look like you're a school-age child that's not being seen by me, but you're accompanying a parent or an adult. I'm like, so what's going on? Are you guys going to school? And then it starts the conversation. And you know, it's not to say that every time there's something negative that's happening or malicious. It's sometimes like, hey, literally, you know, this student just got to the country and we're just waiting for all the papers and immunizations, all that stuff to be up to par to get them into the school system. But it's always good to have that conversation. Say, hey, what's going on? Right?
Because you have no idea what could be going on. Oh God, that stuff scares the hell out of me.
I mean, I think of other things. I mean, when I was working at the health center, you know, we covered Lawrence High School football, and, you know, which was always great. And but the saddest time for me as a clinician was like the senior night, and the seniors being walked onto the field by coaches because the parents didn't show up, or the parents were just working, or the kids were showing up to the games by cab because, and again, usually not malicious. It's just the nature of the community that we work in. And, you know, that those, you know, student athletes didn't have a family member that accompanied them for something that's a milestone, right? That would be really important for them during the course of their lifetime, and show that they were dedicated and played the
Which
sport.
is why places like Greater Lawrence, and there's so many other places like that in difficult communities that's why they're so special and such a real hub of the community. Like, I remember the first time I went to Lowell General Hospital, and I was like, why do they have driver's ed here? Why do they have all these different programs like self-defense women's classes and things like that? And I think one of the funniest things I saw was that they had, because usually I think it's during flu season, they don't want anybody to be visiting if they're under 18 or something like that. And there it was 14. I couldn't understand why. And it was because there were so many pregnancies, and like the dads had to come in and see their kids or something like that. I'm like, oh my, like it's changing just one town to another. The demographics, just the tempo, what's going on from one place to another. Like you can be, I used to do a lot of work with Norwood Hospital back in the day, and very affluent area. Then I started doing work in Dorchester, and I was like, oh, I never had knife wound, gun wound in the ER like before. Now it's like, okay, this is a whole other piece of what's going on. Or you just go to a place that's a bit more blue collar, you're going to have a lot of more broken arms and legs and things like that, just from the manual labor. So it's really interesting. So is there a speaking of, I mentioned that the Olympics, are there any sectors of sports medicine that you have not tackled yet that you're like, you have a wish list or a dream? Like, it would be fun for me to, like, oh, I'd like to get into whatever it is.
Yeah. I mean, I think the one other thing that's probably on my bucket list, maybe to get involved with the Olympics in some capacity. But that also is there's a process that goes into that. So the process that last I checked is that you would volunteer your time to work at one of the training facilities, whether it's in Colorado Springs, up in Lake Placid, maybe somewhere out in California, and you volunteer your time for 2 weeks at the facility.
Oh, wow.
So don't get paid. They don't fly you out there. So it's all on your time.
Yeah.
Right? And as you just mentioned before, I have ample free time on my hands to do things like this.
And with 3 kids, by the way, and a wife at home. So.
Yeah. So not the easiest thing to say, all right, now let me, check this off the list. And so even doing that doesn't guarantee you a spot of traveling with the team for any of their, obviously the Olympic Games, or maybe like the Pan American Games, or maybe something else that's on a smaller scale, but still as prestigious. So it hasn't crossed my, crossed my path yet to do that, just because I'm really busy and really happy with what I do currently. So I don't think adding on a couple of weeks,
maybe like later on in your career or something. Yeah, but it's interesting because I'm sure there's not a short line. I'm sure it's a pretty long line of folks that want to get into that, or it's even for younger physicians, might even be like a resume builder for them.
Of course, Yeah, no,
So.
I mean, it's definitely showed, because I think everyone in the sports medicine community knows this is not just hey, we pick you out of a pool of people because we liked what you saw on LinkedIn. No, you still need to do the work. You still need to show up. You still need to do that and show that you have the dedication to that, and even making some of the sacrifice to do that. So, so I think that's important, for that organization, and they get plenty of people doing it. So
that's great. Wow. I mean, it must be very difficult for you to manage primary care while also having all this traveling. Like, so how do you even schedule that? How do you?
So I think, so I mean, I definitely have a phenomenal team. Even within Mass General, they do a really nice job of supporting primary care physicians, even when they're out of the office for normal days off, right? Normal vacation. So there's a whole team behind the scenes that's called VCS. I think it's called Virtual Clinical Support, that, whenever I put in time off, and recently my managers here, the admin team, are just like, oh no, another Bodine PTO request because something happened where he has to travel with the team. So they put in a calendar request for the VCS team to then cover all the things that come into my inbox through Epic the whole time I'm gone. So there's nothing to worry about. Med refills, test results, summarizing consultations and any updates on patients. So, but the other beauty of, kind of having access to an EMR is that you can do things from afar as well. So there are times I'm still managing things, again, as much as, it's fun to travel with teams, you're not also working 24/7. So you're traveling with the team. You're essentially my role when I work with an organization like either Merrimack College or even working with the Red Sox. You're working to serve not only the people that the athletes that you're assigned to take care of, but I look at it as like you're also helping out the traveling party, right? So like the admin staff that are also traveling, that maybe something comes up, maybe they get a GI bug, maybe they need to be seen. So where are they going to go find an urgent care in South Dakota? I'm sure they're out there, but it's probably not the easiest to get to.
I can't imagine.
So I kind of view my role as, all right, kind of being there on call for everyone that's in the traveling party to help out. I mean, we're not going to, stretch the limits of, my imagination of like, we're going to do surgery on you or anything like that, but do things that I think will make things a little bit more palatable and make people comfortable.
And how does licensing work? Like,
great question there.
You have so many states that you travel to.
Yeah. So there was legislation that was passed not too long ago by Congress that kind of gives the opportunity to the physician that's traveling, when you're traveling with that team or that group, wherever you go to, your license applies.
So they have a carve out for you.
Yeah, there's a carve out.
That makes a lot of sense.
Otherwise, you're not able to do much.
Right.
You're not going to be, heroic and doing surgery on the sideline. Like you can still activate EMS if something like that came up. But in situations like that, you do have that flexibility and latitude to do that.
Okay. Yeah.
Because otherwise I'd have to be licensed in every
Yeah. For the people at home, wherever the patient is. So even if it's telehealth, if you have a patient here and one of your patients is in Rhode Island for whatever reason, they live there, they're going to work there, and they're having their consult, if he's not licensed in Rhode Island, can't treat them. So That's an interesting, yeah, because I mean we deal with I have this LMHC right now that's moving from Mass, Rhode Island to Tennessee, Georgia border, and I'm like, this is not a small undertaking. Like, not only does she have to get licensed in both of those, but the insurance companies, even the national ones, there's a lot of credentialing work that has to be done. It's a very it's not an easy process. So that's great that they have a carve out for you, because it's not like it's an uncommon thing. This is something that's happening all over the place. I mean, even at the young child level, they have these traveling teams, which I don't know how parents do that. I've always been so scared to have a good athlete. I'm so glad that neither of my daughters are crazy athletes.
It's a sacrifice. I mean, what's really, and again, I think the other the highlight of my job is to see that play out, right? To see, like, you know, these athletes playing at the highest level, whether it's collegiate or even professional. Again, you hear the stories all the time. Someone gets called up out of Worcester or Portland and they get brought down to Fenway, and, like, you know, everyone's, you know, there's chronicles of how they're driving, you know, with this, that, and then they'd show up and then the family's there. So it's a really good celebration. But you see that also at the collegiate level. You know, I have a couple of athletes that their parents travel to all the games, home and away. And I go, like, wow, like, do you guys have a full-time job too? Like, how do you pull this off? You guys live in somewhere Connecticut, and you're coming all the way up to North Andover for a time. You're down in Atlantic City for certain things. But yeah, you know, it's great. And then there are times where I'm, like, walking around the arena and, like, the grandparent of said athlete's like, hey, did you see so-and-so? They were limping. I'm like, all right, I'll make sure I'll take a look at that. They didn't tell me anything, but I'll be sure to take a peek.
I love it. All right, let's see how we do with time. Okay, we're doing pretty good with time. So let's get into, I have just one more phase I really want to get into. I don't want to go super deep. We did orthobiologics last season with Dr. Sussman.
Yeah.
I think it was episode 3, season 1. So without getting into that, just kind of, I think a good finishing topic would be getting into what you see moving forward, because sports medicine is a very interesting field right now. Might be one of the most interesting and very evolving of all the specialties that's going on right now. And there's a lot of controversy. There's, you know, one of the things that I tried to pin Walter on, but he didn't bite because he's smart, was about, you know, there's situations where some of your patients aren't going to have any cartilage, so they're going to need surgery. He's like, absolutely. And I was like, so does that happen the opposite way, where, like, if a surgeon has somebody with that clearly could be worked on by your team? He was like, we work very much with us. I was like, oh, like, because I have this very strong feeling, but I don't think, and I don't expect you to answer, that, you know, it's not as often being kicked back to practices like those for, like, the PHP, PRP treatment,
Prolo,
and stuff like that. Which I think the thing that I care about most about that is not the turf war, but it's more of education for patients, because that's one of the things I like about this show that we do, is that I like to let people know about certain services that are out there, not just people with very interesting stories, like you have a very interesting career, but also understanding, you know, what is out there that you can do to potentially avoid things like, I mean, I've had several surgeries. It's not, so when my youngest daughter, when she was 3, they said they wanted to perform surgery on her. I held out till she was 5 until it was clear there was no other option for her to have it, because I just know, like, it can create, like we talked about mental health earlier, trauma is certainly a big part of it. And some people, especially when you're dealing with, like, spinal fusion and stuff, there's permanent changes that you can make to your body. So I like to go into those situations with making sure people have the most information that they can possibly get. And some of the stuff is so, like, you have the stem cell stuff, and then the exomes, I think, is even more emerging than that. And that's as far as I know. But I guess I could barely say that I even know it. But I guess my question to you is, like, how interesting and excited are you with where sports med is now and where it's going? And is there any, if you could prognosticate anything, you know, where do you see things going in the next 10 or 20 years with the field?
Yeah, I mean, I think overall, and then not speaking as an orthopedic surgeon, but I know I work with a lot of them. I think if there's kind of that acceptance that there are these other modalities and treatments that are out there, I think being open-minded, you know, because again, at the end of the day, you have to look through the lens of your patient, right? Not just what you do. And I think, you know, coming from my educational background, teaching in residencies, I think, we just think about the lifespan of a physician, right? Med student just absorbing a lot of information, residency even more. And then you finish residency, you feel like, all right, well, kind of, this is where I'm at. I'm at the top of my game. Like, this is just where I'm going to stop learning. And I think that's where people sell themselves short. And I think that's sometimes the mindset, especially within some of the subspecialties, is that, you go down this rabbit hole, like, all right, and even within our Mass General system, there's like a shoulder team and an elbow team and a hand team and a foot team and an ankle team, right? So because that's what's expected, right? You want the people that just do with that all the time.
Yeah.
But with that, I think sometimes that trade-off is that that's all you do all the time.
Yeah.
And you don't have maybe that appreciation. So I think that changing that mindset within orthopedics, where from a surgical perspective, and one of my colleagues kind of coined this phrase, like, transitioning yourself from like a carpenter to a scientist.
Yeah.
And I think that's where kind of ortho is going.
It's such a great, so, and I've heard this a lot about Eastern medicine, that Eastern medicine is very much generalized and more of a preventative medicine type of focus.
Right.
They don't have the insane subspecialties like how you just ran through that we have. And it's so hard to pick and choose because both of them have so much validity to them, depending on what the patient needs are. I mean, the folks practicing more of an Eastern medicine are never going to have that level of specialization and understanding of, like, if all you do is foot, like you are going to be, that's who I want to do to manage my issue, right? But but a lot of that is the reactive side of things too. Within our medicine is still very much on the reactive side. Just like how we wanted to move everything to, like, I'm in the billing world.
Yeah, of course.
How long I have heard fee for service is dead. This is the end of it. This is the year. It's not. It hasn't come. We would like to have things based on, quality metrics and all this other stuff, but and we get force fed these quality metrics out of garbage. That's a different show. But I have this other guy we're going to be doing later on the year, and he's like similar to me, but in a different field. But we both hate insurance companies equally, so it's going to be like probably a 45-minute bash session on insurance companies. So that'll be something to look for later. But I guess it's interesting the way that you look at how these different methods of consideration should be taken. I feel very strongly, like I told you, like 6 or 7 years ago, I got into woodworking. Just last year, I started getting into auto repair type of stuff. And I'm such a firm believer that if you do not try something new, you do not grow. Like, you should always be ambitious, even if you're gonna, and believe me, I have embarrassed the hell out of myself more times than I've been successful. But I don't care. Yes, absolutely. Like, I can't even tell you how terribly I did a brake job a couple weeks ago. But that being said, I'm never going to make those mistakes again. But overall, I guess the point that I'm trying to make is that, you should always be open to the fact that what was true and was factual in the best form of medicine yesterday means squadouche today.
Correct.
And God knows what's going to come tomorrow.
Right. Exactly. I mean, again, I have plenty of patients that come to see me after they've had way too many cortisone injections, more than I can count, or more than any human should have ever had injected into said body part. And again, I think it just comes down to, what access that those patients may have to some of the other resources in the community, right? I mean, I think even at my time at the health center, even orthopedics was not really considered an essential service line for a federally qualified health center. Meanwhile, it's,
I wonder if it is now. Is it now?
I don't know if it is or not. I mean, things get a little bit complicated with, what's covered under the malpractice liability under FQHC. So even when I was doing work with high school teams, we had to get secondary malpractice insurance to cover that because it was not covered under scope. But again, you think about, all right, that's outside the exam room, but in the exam room, you're dealing with, patients that are living very thin margins within the poverty lines, that are working jobs that are certainly stressing them physically, mentally, emotionally, but more often than not, musculoskeletally. And their access to musculoskeletal expertise was limited because, folks may have health safety net, and the only places that takes health safety net was Boston Medical Center. So now just visualize a person with a type of injury, fracture, doesn't have access to a car, has to now hobble onto the commuter rail from Lawrence, take the commuter rail downtown, and a couple of other things to get to BMC.
Okay.
It's a full day affair.
Damn.
And also they're injured and they're crutching or they're in a wheelchair.
And exacerbating potentially what they have going on.
Right. So in having that type of service line that was embedded in the health center, I think was really critically valuable, not only to the patients, but then also to the primary care doctors that were seeing these patients.
Right.
Having a familiar face or faces that were seeing their patients, caring for them, and knowing that they could take care of a certain issue and then escalate outside the health center only when necessary, where, maybe, if we weren't there, that a lot of musculoskeletal injuries might have just been shipped out prematurely.
Sure. And how when you were there, were there many DOs there?
Yeah, there were. Yeah.
Oh, okay.
Yeah,
good.
there were. Yeah.
Yeah, I never got a breakdown when I was working there.
Yeah, there were a handful. It wasn't the majority for sure.
Sure. I mean, I think it not often unless you are in sports medicine, then certainly then you guys can then bully them around for once. Keep them D's.
No, we all. Oh no, we don't. No, we all play well. We all play well in the sandbox. My MD and DO colleagues are well respected all across our system. Like I said, I think everyone brings a different perspective, right? And I think I agree. I still do some manual medicine, and I still do a lot of manual medicine on our athletes. And in fact, this past weekend, I did some adjustments on one of the hockey players before the game at a meal. And then 6 other guys showed up on the line behind me. They're like, "Oh, we didn't realize you did this." I'm like, "Well, your hockey guys usually don't come out to see me unless something's really bad." To get back to your original point. Right.
It's like when you're a kid going to school and you see your teacher outside of the school, and it's like the most earth-shattering experience. Like, wait, you go to restaurants, you eat?
You eat too?
You have a house? Okay, great. All right. So I think we're probably, we're just about at 12 o'clock. So I think we'll close it out here. Sure. This is awesome. I really appreciate you coming here to do this. And I guess let's leave it off with something. Let's do a cute little exercise to leave it off. You have anything in your head for this?
I don't.
Okay. I mean, since you didn't want to beat up on the MDs, which was a golden opportunity. I think it's funny too, because you do still have some of that rub. Like, I don't know. It's kind of like racism or something maybe, where it's just like, some people are so full, like how people can still think these ways, but whether it's with the MDs and DOs, I don't know that I've actually ever seen it in my lifetime. I've only heard of stupid situations in the past from like folks that I've worked with. It's really silly. But I think that, if you were, let's go. I think I have an idea.
Sure.
So one of the things that as I said earlier, strive for here is to try to give folks some information that they may not have had before. So if you're a DO that performs primary care, personally, and God, you're probably not going to be able to answer this, damn. But like, I would think that folks who are athletes, student athletes in particular, are better off having somebody with those type of credentials than an MD. In the same way that if you have chronic cardiopulmonary issues, you should look for your PCP to have some kind of a discipline. Maybe they're board certified in something, or at least have an interest in that, versus like someone that's going to focus on GI or something like that. Like, so if you have reflux disease, you should be paying more attention to like what the specialties are or subspecialties that your PCP might have. Would you agree with that? Or?
Yeah, I mean, I think, primary care is such a large portion of our healthcare system, and there are so many nuances to it. And I think, you can certainly wish for the stars and making sure, your primary care physician checks all the boxes. Yeah. And sometimes there are patients I meet that resonates with them because they are an athlete, or they were an athlete, or they're a weekend warrior, and, making sure that they know someone that has that expertise and background and kind of can streamline things for them moving forward. But that's not always an ask for folks. And even within osteopathic medical education, yes, we get a ton of hands-on and musculoskeletal education, right? But I can't say that my pathology med school classmates are utilizing that right now. And I can't say that even maybe all my primary care colleagues are utilizing that expertise right now because of
Right.
maybe the situation that they're in. Maybe they don't feel as confident in their exam skills now because they're so far out from residency. And they say, you know what, I joined a group that we have this working relationship with this ortho group that's next door. For
Yep.
anything that's musculoskeletal, we send them their way, and then that's
Mm.
it, right? So then you start to then see all right, now my knee-jerk reflex, pun intended, is to then send them to the orthopedist. So therefore, your exposure to orthopedic conditions
Right.
and managing them also drops off considerably.
Okay.
So I think it really comes down to the environment that you're in. And
Yeah.
I always tell, residents and early career clinicians is to maintain whatever skill set you're passionate about, maintain it for as long as you can, as long as it's still something that brings you joy, and more importantly, something that brings benefit to your patients. Because the minute you start to shut those doors, it's really hard to reopen them.
Okay.
Again, it's really hard to learn something new as an
Absolutely.
adult because it takes time, effort, energy.
Sure.
But it's not a completely closed door conversation. It doesn't shut it completely, but it's a little bit more difficult to open it up
Right.
once you've kind of.
And I imagine most people probably just choose PCPs based on relationship. I like this person, they spend extra time with me, or I like people who are less emotional, much more like, hey, this is blah blah, like just tell me like it is, don't sugarcoat it, get me out of here, like I'm
Right.
But like and I think a lot of people gravitate to that, and I guess that's not necessarily terribly worse. I guess if you have probably some particular needs, then maybe it makes sense for you to delve into that, and otherwise if you're just really looking for a generalist, then it's probably more about that connection that you have with the doctor.
Yeah, definitely. I think even in my role with working with the college and even professional teams, I'm one person on a larger team. And even within that subset, I'll find there are certain athletes and patients that will resonate to maybe one of my colleagues more so than me because of X, Y, or Z, whether they have a good relationship, whether that person was there when that injury or illness happened, and they just have a good working kind of rapport with one another. You just can't take it personally. We're all working together for the same goal. We're trying to provide, high quality evidence-based, care for the people that are, that we're blessed enough to take care of.
And which location is your practice?
So it's here at 500 Merrimack Street in Lawrence. So that's my primary care practice, and my orthopedic sports medicine practice is literally 5 minutes up the road in North Andover.
Beautiful.
Yeah.
Okay, so you heard it. DO's better than MDs. No. Thank you, guys. We'll see you at the next one.
Awesome.
Did I hit the run right? I don't think I did. Leave the studio. Let's end the stream. Okay.